Welcome to part one of the congenital heart defects. So this will be chapter 24 in my copy of your book. When we're looking at this is going to be important, especially if you work at a place with a level 4 NICU or a very high functioning level 3 NICU. This is still really good information too if you're going to be working at a NICU in almost any facility, in case you have someone coming in let's say there's a car accident and the mom is with child and they have to deliver the kid and the kid happens to have a hypoplastic left heart. How would you treat that? What would you do initially until you get them to a higher level NICU? Like, how would you approach the ventilation and oxygenation strategy of that kid? How would you approach the care? So this is going to be sort of the application. Understand that this is information directly from your material in your chapter, and it's not meant to override any current evidence or studies that are out there. So a lot of things just come out year after year on better ways to treat things like a hypoplastic left heart syndrome or a microganthia and so on and so forth. So this is focused on congenital heart defects, but understand that as time goes on, the procedures change, the approach may change a little bit, but I'll give you sort of where things are currently at as of how your textbook explains it. So this is just the general approach. Like I said, understand this is why you need to stay current out there, go to conferences, continue CEUs through the AARC, continue getting that knowledge out there, because things change, things advance, and sometimes when things do advance and when things do change, they change for the better, right? Obviously, that's the whole plan, and we might have a lot simpler, better approach in the future. So stay up to date, right? That's my whole bullet point for this. Stay up to date on where the treatments are currently as you go throughout your career. Hey, if I had to have a kid come in and something weird was going on, what would I do? So you got to plan for those cases. I want you guys to be prepared. Even if it never happens, I still want you to be prepared, because you'd be a lot better being prepared for it and it never happened than having it happen to you and not being prepared, right? I told you guys the story when I was working ER and someone came in. The kid was born at home, working hard to breathe. They brought the kid in, and then the kid ended up having a choanal atresia. So the kid couldn't breathe through their nose. And so whenever I put the kid on his stomach, he'd breathe just fine, right? It pulled the tongue forward. It's sort of like a weird jaw thrust, right? Where you don't have to jaw thrust when you put the kid sort of on his belly there. Now, that's not like the back to sleep program, but he wasn't grunting. He wasn't cyanotic. He wasn't working hard to breathe. If he was sort of in that swimming position, if you will, sort of on that belly position. So that's what kept him stable until we were able to get him to a level 4 nursery where they could eventually do surgical procedures and do all their fixes that they do with those magic people there. But just little things like that can be a big difference. So just always have a plan, stay up to date, and do the best you can, right? Let's get into this. All right, so let's talk about classifying some of these heart defects. There's a lot of different classification categories out there. So some of them look at the presence or lack of cyanosis. So you might have heard me talk about this before, if it's a cyanotic or an acyanotic shunt. And that's a lot of times what we'll be talking about in the NICU as well, if it produces cyanosis or if it does not produce cyanosis. So we'll start talking about those in this presentation and the next one too. Sometimes they'll classify by the shunt type. Lesions that result in obstructed blood flow, we'll talk about that as well. Miscellaneous structural lesions that could happen where they could classify it there. Traditionally, you're going to see it as a cyanotic or an acyanotic classification. That's just with my mileage. Your mileage may vary. So shunting, remember, is the movement. So here I'm going to do one of our classic drawings. Let's do the alveoli as green. Then we'll do a blood vessel. So remember, the definition of a shunt is blood flow. So we have perfusion without gas exchange. So perfusion without ventilation. So this blood stays purple, right? It stays desaturated. So in one way or another, it does not exchange gas. It does not drop off CO2. It does not pick up oxygen. Whether this is a lung fault, right, the alveolar capillary membrane fault, like severe atelectasis is like a shunt-like disorder, or it's something where you have a hole in between the left and the right atria, and there's higher right atrial pressure than left atrial pressure, so that would cause a right to left shunt, right? And that's what you're looking at here. And so this type of a shunt produces cyanosis. Now we'll get into things like with a PDA, a patent ductus arteriosus, that's actually an acyanotic shunt. In other words, we have twice as long in the diastole where we have good blood from the left side going into the pulmonary artery. So it actually has twice as much good blood as it does bad blood mixing. So therefore it's ultimately an acyanotic shunt. So you'll sort of see us classify methcyanotic and acyanotic. Now understand one of the big bullet points, and we'll go through that here as well, is when we go through the shunts, there's what we call shunt-dependent kids. So in the example earlier where I was talking about hypoplastic left heart syndrome, where the left ventricle really isn't formed at all, we need to keep that PDA of that kid open, right? We need to keep that PDA open, because how else are we going to get blood to systemic circulation? It can't go through the left ventricle. It can't go from the left atria to the left ventricle. That's not a route that it can go. So the only way you can get any type of blood to perfuse the extremities, to perfuse the rest of the body, is to actually leave the PDA open or purposely keep it open. So if that PDA starts to close off on that kid that has a hypoplastic left heart, then obviously their blood pressure is going to drop, because obviously there's no blood flowing to the rest of their organs, to the rest of their body. Nothing's going through their aorta, right, if that PDA closes. And so you're going to see not only their blood pressure drop, but you're also going to see their whole body turn extremely pale, dusky, cyanotic. So we'll see kids that are what we call shunt dependent. Those are important to remember, because if you have a kid, let's say you go to a delivery, and you giving a kid oxygen, or it's been a couple hours since delivery and their shunt's starting to close, and sure enough, their heart rate, their blood pressure, everything's starting to look terrible. They're starting to shut down, right? Babies like to shut down for some reason, right? That's the whole dive moral reflex thing. So that kid starts to shut down. You're going to want to understand what could be the cause. And one of the causes for that kid shutting down is that they were shunt dependent, right? They had a cardiac defect that was dependent upon those shunts staying open to help them perfuse. So we'll talk about the severities of each individual one, but keep an eye out. I would make a little separate list, like pull out a 3x5 card, or make a little separate list of shunt-dependent kids, and how do we treat a shunt-dependent kid, right? What happens if you're a kid, you're giving them oxygen, and you start to see them shutting down? You start to see them become cyanotic. You start to see their blood pressure and their pulse. You don't feel their pulse. It starts to drop. What would you do, right? So keep in mind the treatment, as well as the conditions that are shunt dependent. I will tell you this, if you ever had a delivery and a kid shunt dependent, you didn't know it, but then all of a sudden you started seeing the signs that that kid was dependent on that shunt, you're gonna want to know how to respond. That is definitely a moment of, oh, I wish I studied this more. Or it could be a moment of glory where you're like, I'm glad I remembered. It could be one of these, but I'm gonna treat it the same. All of them are sort of treated the same initially as far as what we would do at the bedside, but hopefully I'll help you out a little bit here just by doing this little warning story. Like, you're gonna want to know if this kid has a shunt dependent issue, and if you don't know and the kid starts tanking, you'll find out pretty quickly. Then you're going to want to know, what can I do to reverse this? How can I get that shunt back open as soon as I possibly can? All right, so shunting in a right to left direction is what they consider cyanotic lesion. So here, let's do this. Let's draw a heart. Let's go with red. Why not? So a right to left shunt means we're mixing bad deoxygenated, because remember the vena cavas, the superior and inferior vena cava, we're mixing bad deoxygenated blood. So let's say it's we have a baby that has severe pulmonary hypertension. Okay, so we have a baby that has severe pulmonary hypertension. What happens to the right ventricular pressure in pulmonary hypertension? Well, the right ventricular pressure or right ventricular stroke work index will increase. What will happen to the right atrial pressure in this case? Well, the right atrial pressure will then subsequently increase, right? We have a backup of pressure, right? Because the pulmonary artery, the pulmonary vasculature are clamped, they're tight, they're back pressuring it. It's like clamping a hose and you see all the back pressure of the water just behind a hose, right? Before where the clamp is, right? That proximal to the house or whatever. So we're having that backup of pressure. Well, let's say the patient has a patent foraminal valve. So they have a little opening here, a PFO. Well, if the right atrial pressure is greater than the left atrial pressure, we're going to have that bad blood flow into the good side, right? Remember, left atria is supposed to be oxygenated blood that then goes to the left ventricle, which then sends it through the aorta and sends it to the rest of the body, right? That healthy sort of blood flow. But when we have this mixing, instead of just this pure, good, rich oxygen blood flow that's in the left atria, now we're mixing that left atrial blood with deoxygenated venous blood. And then that deoxygenated venous blood mixes, right? And then with the oxygenated blood, and then ultimately that deoxygenated mixed blood gets sent through the rest of the body. So anything that's a left to right shunt would be acyanotic. Anything that's a right to left, which is what I just explained, like the PFO here, that would be a right to left shunt where we have bad blood going to good side. That would be cyanotic, right? You'd see cyanosis in this situation. Now, traditionally, a PFO is not a cyanotic shunt because what pressure is usually larger once the kid transitions to extrauterine circulation? Once they traditionally switch to extrauterine circulation, left atrial pressure is higher than right atrial pressure. And so if that's open, let's draw another one here. I know you guys love my drawing, so, tip kindly. I'm just joking. All right. When we're looking at the traditional PFO, so here we'll do the aorta, we'll do our vena cava, superior vena cava. So traditionally, if we have high left atrial pressure, which is how it should be if we don't have pulmonary hypertension, right? We don't have acidosis, we don't have hypoxia, then that pulmonary hypertension won't be there. So if we have a PFO, once that left atrial pressure is higher than the right atrial pressure, that one-way valve, that is the patent foraminal valve, usually closes. So once that pressure changes, that left atrial pressure will close off that little one-way valve there. So it's sort of like a Passimir valve. Do you guys remember a Passimir valve? Where it lets gas out, but not back in because it's a one-way valve, right? That goes on. That one should have been purple because it lets gas out, but when the patient stops exhaling, right? So that way the patient, so when the patient breathes, they can breathe in, right? So this would be their trachea. They're breathing gas into their trachea. And then when the patient's done breathing in, these little valves close, and then the patient can exhale through there and around their tracheostomy tube. So it's sort of the same thing. It's a one-way valve. So when the left atrial pressure is higher than the right atrial pressure, that's when that patent foraminal valve closes. So what happens if it doesn't close? What happens if it's open? Or what happens if we have an atrial septal defect? Well, not a lot. So what happens here is now we have a left to right shunt. That means we have good oxygenated blood that's mixing with the right atrial, that's mixing with the right ventricle, right? So we're having the good blood mixed with the bad side. And in that case, are we going to see cyanosis? No, not at all, right? Because we're not mixing bad blood with good blood. We're mixing good blood with bad blood. So right to left shunt, I want you to think cyanosis. Right to left shunt, think cyanosis. Left to right shunt, right? This is where we're looking a cyanotic shunt ultimately when we're looking at this, like a VSD, an ASD, a PFO. So when we get into it, I'll talk about right to left or left to right. So cyanotic would be right to left. Acyanotic would be left to right. All right, just understand, because of the left to right shunting, the patient could still have a possibility of cyanosis. Well, that's because the cardiac output might suffer, because what's happening over here when we're looking at this situation over here with the PFO that didn't close, what happens to your cardiac output? What happens to the volume of blood that's dumping into the left ventricle? Do we have the same volume of blood dumping into the left ventricle as we normally would? Absolutely not. So what's going to happen to the cardiac output? What's going to happen to the stroke volume? Well, those will decrease. Well, what happens to your cardiac output when that, right? It decreases because there's less volume of blood in there, and therefore ultimately they might become cyanotic, because is there enough oxygen delivery? If we reduce the volume of blood that's being perfused to the tissues, they could easily use up whatever volume of oxygen is in that blood. It can be used up very quickly because there's not a lot of volume totally. So this patient could still ultimately become cyanotic with a left to right shunt if their blood pressure is low enough. That's the key term. Their blood pressure, if it's low enough, right, they have a low mean arterial pressure, if they have a low enough systolic pressure, they can become cyanotic with the left to right shunt because it's impacting their cardiac output. Their body's still going to have the same VO2 requirements. So now we're going to have to worry about this left to right shunt being cyanotic if it really does impact their blood pressure. Right, that's where it can happen. So just understand that, and hopefully that makes sense. If not, we can talk about it in one of our classes or meetings here. All right, so let's shed some light on this. So the right to left shunt, this would be your desaturated systemic venous blood that's bypassing the lungs and going into systemic circulation. So the classic case on this is, especially in utero, is going to be your patent ductus arteriosus, right? So here's your pulmonary artery, and I'm sure you guys are way better artists than I am. Here's your aorta, right? And then this is sort of that connection in between the two. Here, and this is in utero, this is normal. You don't need but 10% of your blood volume going to your lungs, and that's just for lung development. That's about it when you're in utero. And so you don't need it going there. So most of that blood is going to be going through the pulmonary artery, right, straight through that patent ductus arteriosus, straight into the aorta. So that's how it normally is. So this is desaturated blood that's bypassing bypassing the lungs and entering systemic circulation, right? That is a classic definition of a right to left shunt in utero. All right, deoxygenated blood mixing with good stuff, but just remember, it's not deoxygenated blood in utero, but that's a whole separate thing. A left to right shunt means you have good blood, good oxygenated blood, mixing with bad deoxygenated blood. So is this going to change your saturation? Right? No. So no SpO2 change. This one would be yes. SpO2 change. All right, so remember that just in general, right? I'm speaking in generalities. Right to left shunts usually do cause cyanosis. Left to right shunts generally do not cause cyanosis. Now, did I just give you a case a second ago about how if it impacts the cardiac output, it can cause cyanosis? Yes. And that's what can make this so confusing sometimes. So please don't focus on those. I just want you to understand the basics, and then we can go back to those cases where even though it's acyanotic, they're cyanotic, right? But that's because they're so sick with what's going on. Okay, so let's move on to this next bullet point here. A right to left shunt often present with central cyanosis, and they'll stay that way if it's a significant right to left shunt. Remember, that's bad blood mixing with good blood. They'll stay centrally cyanotic, and sometimes you want to keep that right to left shunt open in certain congenital heart defects, so that sometimes we're okay with a baby that's a little bit blue, a little bit dusky, as long as they're survivable until we can get them the appropriate procedures they need. That's what we have to do. And we might even do something where we give them nitrogen, right? We might give them hypoxic gas therapy. It's pretty crazy stuff. So we'll talk about that later on as well. A left to right shunt often appear pink, right? So most of your babies that you'll take care of in the NICU, the big thing that you're going to see is this patent ductus arteriosus for preemies. So if it's a preemie baby in the NICU, they're going to be pink. They're not going to have that cyanosis part to them because traditionally it's considered a left to right shunt. And so in that situation, you do have to be concerned with pulmonary edema and diluting surfactant, right? In developing RDS because of this whole left to right shunt situation. You do have to be concerned with that. But overall, it's not considered a cyanotic shunt. So often these kids are pink. It's there, that shunt is there, but it's not affecting their saturation. It's not affecting their ability to deliver oxygen to their tissues unless their blood pressure is low. The left to right prolonged shunt. So a left to right shunt. This is what we just talked about. What will happen to the blood volume? Okay, so look at this drawing now. So we have a lot of blood volume in the aorta. And what happens when this extra blood volume floods into the pulmonary circulation? What will happen to pulmonary vascular resistance if we put tons of volume of blood in here? Will the pulmonary vascular resistance increase with all this extra blood in there, or will it decrease with all this extra blood in there? Well, what happens to the highway if you have tons and tons and tons of vehicles on it, right? Rush hour traffic versus non-rush hour traffic, right? So when we have a left to right shunt and it's prolonged, like we have it over a long time period, it will increase pulmonary vascular resistance. Okay, so which means what's going to happen to the pulmonary blood flow? Well, we're going to have an increase in pulmonary blood flow, which then ultimately, if we have high enough osmotic pressure or high enough pressure in the capillaries, those capillaries are going to do what? If we have enough blood volume in here, right? If the capillary pressure is high enough, it's going to leak fluid into the alveoli. That's going to cause that pulmonary edema component, right? It's almost like your cardiogenic pulmonary edema that you see with CHF patients, right? That blood volume overload, because that left ventricle is not squeezing, they have that backup of pressure in their pulmonary vascular system, which then weeps fluid into the alveoli. And that's exactly what you're seeing here, except for the left ventricle isn't the fault. The fault here is the pulmonary blood volume has increased, as we see with the picture right next to it here, right? We increased that pulmonary blood volume, which then back pressured and made that go on. So that increases pulmonary blood flow. Remember, then that's where we see that propensity for pulmonary edema. All right, next bullet point. In a right to left prolonged shunt. So right to left is the cyanosis, right? This is the one we're going from the bad side to the good side. We're mixing the bad with the good, and that's not good in a social situation, let alone anything else. So with the right to left shunt, you're going to see cyanosis, which will do what to delivery of oxygen to the organs, right? We're going to have a diminished DO2. Our DO2 is going to be very, very, very poor ultimately with these babies. So we're going to have to watch out their kidney function. Are they stooling? Are they having wet diapers? Right. So these are things that we need to be watching with these kids, because that's going to be a big issue. Are their organs staying and working appropriately, or are they having the start of multi-organ system dysfunction or multi-organ system failure, right? It's going to be a big issue. So as you can see, With left to right shunts and right to left shunts, it's both of them are important to know. I want to know if my baby, or the baby, sorry, not my baby, but the baby that you're assigned to in the NICU has a left to right shunt that's going on. So if their x-ray starts looking like ground glass opacities, GGOs, and their lung compliance starts decreasing and their FiO2 requirements start increasing, maybe it's pulmonary edema and not RDS. Does that make sense? And so what's the big deal? What's the big difference? Well, one of them is a lot more serious than the other when it comes down to it. Did your kid just get a blood transfusion? Is it odds are if the blood transfusion, they didn't give like a diuretic afterwards, they might have a volume overload. They might be in pulmonary edema. That's why their FiO2s are currently high. That's why their x-ray looks ground glass. That's why all that stuff. Because remember, pulmonary edema and ARDS, if we're talking the adult world, pulmonary edema and ARDS almost look identical to each other, but physiologically, one clears up a lot better and a lot faster than the other, okay? So you're going to want to know if it's RDS versus something like a pulmonary edema. In adults, right? I told you guys before, I had an adult patient that came back from the OR who had low blood pressure during a surgery, and they gave him 5 liters of fluid. And they were saying, oh, this patient is in ARDS. Well, yes, their PF ratio showed that they were in ARDS. Their x-ray looked like ground glass. They had very low lung compliance because of all the fluid that's diluting the surfactant in their lungs, right? So everything looked like ARDS, and I would agree with them initially until I heard that they gave them 5 liters of fluid. That tells me this is more likely pulmonary edema. And then a couple hours later, as long as their kidneys are on board and they're filtering and getting rid of some of that fluid, if their hemodynamics are stable enough and their renal function stable enough, that it'll clear up. And sure enough, the next day, magically, he was cleared of ARDS. What do you know? So in that case, it was more of a pulmonary edema case than an ARDS case. Well, I'm asking you to transfer that line of thinking to this situation as well. So is it possible that this kid is going into RDS? Yeah, it's possible this kid's going into RDS, but is it also possible that this could be a left to right shunt causing the current situation, and we should look at treating that? So these are the discussions I want you to have. These are the thoughts I want you to think, and I'm not trying to tell you how to think. I'm trying to give you an avenue of how open up and expand your line of thinking instead of just, hey, the neonatologist says it's RDS. I want you to be in that conversation. How is it RDS compared to something like a pulmonary edema, especially when you look at, did they get a recent transfusion of platelets and things like this, right? I want you to be in on that conversation. I want you to be thinking critically with this. I'm not trying to make you think the way I think. I'm just trying to expand your critical thinking process here. So hopefully you appreciate it. I know I'm a little long-winded there, but I'll keep going. All right, this next part, notice it is in bold and important, and this is what I was talking about before. I would make like a little thing of shunt dependent lesions is what or shunt dependent conditions when you're looking at this. So these are shunts that are dependent, that where if the ductus closes, right, if the shunts close, then that kid's blood pressure will drop. We won't be able to circulate any blood to their organs, to their brain, so on and so forth, and they'll go cyanotic. They'll just go into a complete code situation. So these are the ones that are important to know, and we'll talk about these, and your book also talks about these as well. But critical coarctation of the aorta. So if the aorta has a coarctation, and you'll see it like pinched in. So if it's pinched in here, and it has a severe obstruction. Now, we're not talking about just like a little squeeze in, like a little clamp, but a severe pinch in there where it's really obstructing flow. And we have, here, let's do the pulmonary artery. We have a ductus arteriosus here. Hopefully my drawings help out a little bit. What's going to happen here is, with this baby, if you're looking at this unique drawing that I did. If we have a baby that has this severe coarctation here, what's happening to the volume of blood that's getting to the systemic circulation? If that PDA is closed, hardly any blood is getting to systemic circulation, which includes blood flow to their kidneys, livers. So it includes digestion, it includes a lot of systems that we need perfusion to. However, if we keep the PDA open, even though it's even though it's here and some of it is deoxygenated blood, we can still deliver volume of blood to systemic circulation. We can bypass that. So we might have to, if it's a severe enough coarctation, and depending on the location of the coarctation, right? So I just drew an example of how a PDA can actually help you get an adequate blood pressure on this kid. Right? So same thing with the hypoplastic left heart syndrome. That left ventricle is not squeezing anything to the rest of the body. So your only bet to squeeze blood to the rest of the body is to keep this PDA open. Right? Does that make sense? Pulmonary stenosis, same thing. We'll talk about all these individually. So sometimes we need to keep these open so that ASD, sometimes they can go in and do a balloon dilation of the not the ASD, the PFO, patent foraminal valve. They can go in and actually reopen or open that patent foraminal valve so we have some blood flow. It's pretty crazy. So we'll talk about those in detail, but in this situation, you're not going to want to use high FiO2s. You're not going to want to use things like nitric oxide. You're not going to use those things, and we'll talk about them in a little bit here. So the first one we'll talk about here is a PDA. I know I've sort of like hit PDA hard with you already. Obviously, it's a pretty important shunt to know. So the patent ductus arteriosus, you have deoxygenated blood from the pulmonary artery going to the aorta, which bypasses and I couldn't resist, Yes, the lungs. So this is a direct bypass of the lungs. This is something that's natural and normal for intrauterine circulation, but for extrauterine circulation, not so normal, right? This is what should close off pretty soon after birth, assuming that we don't need to keep it open or they don't need to keep it open. Remember, this close as a result from increase in P little AO2 and a decrease in PGE2. So PGE2, real quick, a little sidebar on PGE2, if you will. PGE2 actually keeps the patent ductus arteriosus open. Now, there's a different prostaglandin that we can give that will close it. So we have prostaglandins that will keep it open and prostaglandins that close it. So since there's a decrease in PGE2, guess which keeps it open? Guess which prostaglandins you might want to give if they have a critical of a shunt-dependent cardiac defect. If they have a shunt-dependent cardiac defect, take a wild guess. PGE2 is going to be your best friend there because it's going to keep that PDA open. And also, what are you going to do to their FiO2s and PaO2s? You're going to want to keep them low if you want to keep that PDA open. Well, if we want to close it, obviously we'll make sure they have an adequate PaO2. And as they have an adequate PaO2, there'll be a decrease in prostaglandins and it should close it, right? PGE2 is something that's secreted by the placenta, so that's something that once the baby's disconnected from the placenta, once they're no longer getting blood flow and blood supply from the placenta, that's something that starts diminishing right away, which helps with their transition to extrauterine circulation. Fun stuff there. The most common, and this is something I might test you on, hint, exam 3, the most common cause of a PDA is prematurity. And that's fine. It's almost every neonate, premature neonate that you will see up in the NICU has a PDA going on. Right? They're not supposed to have a closed PDA yet. So the PDA will be intermittent. It'll open, it'll close. It'll open, it'll close. You'll see that change in their pulse pressure. Remember we talked about that before where you have an increase in systolic and a decrease in diastolic because of the physiology of it. So you'll see that go on. So one of the things that you can do here with these, if it opens and closes all the time and we're trying to titrate FiO2s, is do that pre-post ductal monitoring, right? We're titrating for the pre-ductal. Other causes of the PDA or the ductus staying open is premature pulmonary hypertension of the newborn. So pulmonary hypertension is a big deal here. So if a kid has pulmonary hypertension, one of the quickest fixes we can do is FiO2 so that they're not premature, right? So the more premature a kid is, or the more early a kid is in their birth process, the gestation, right? The younger the gestation, the less likely you want to use higher FiO2s because they're more prone to oxidative injury the more gestational early they are. Hopefully that made sense, but if a kid is term, so let's say we have a kid that is a meconium aspiration and it caused pulmonary hypertension. Can we use FiO2s or higher FiO2s on that kid or higher saturation goals on that kid without causing oxidative injury and possibly causing retinopathy or prematurity? Absolutely. Right, so if you have a term kid or post-term kid, we can use higher FiO2s. Now it's going to feel weird because you're used to taking care of mostly preemies, but if you have that term or post-term kid that has pulmonary hypertension, you don't have things like nitric or sildenafil, aka Viagra. If you don't have all those, then you might just use FiO2 for a little while. They're not as prone to oxidative injury if they're term kids. The more preterm they are, the more prone they are to FiO2s, higher FiO2s causing oxidative injury. All right, other things that can cause that PDA to stay open is RDS, the development of RDS. Because what does RDS, just like ARDS, what happens to the pulmonary vascular resistance? What happens to the pulmonary capillaries? So if you're looking at your pulmonary capillary or your AC membrane here, what happens to your what happens to your pulmonary capillaries with hypoxemia? Do they dilate or do they constrict, right? They would constrict. So with hypoxemia, you cause pulmonary hypertension. That's why one of the best fixes for someone that has chronic pulmonary hypertension is give them oxygen, supplemental oxygen here. So if a kid has RDS and they're not getting a lot of oxygen to their AC membrane, they're not getting a lot of oxygen to their alveoli, then they're not going to be able to get a lot of oxygen to those capillaries, and a decreased oxygen level in the capillaries, in the pulmonary capillaries, will cause constriction, which then causes pulmonary hypertension because this constricts, so it squeezes it and causes pulmonary hypertension. That pulmonary hypertension backs up into, remember, the pulmonary artery. Good old pulmonary artery. Well, it backs up into the pulmonary artery, and then what happens to the, let's go back to the PDA drawing again. So what happens to the pulmonary artery pressure? Well, the pulmonary artery pressure is going to increase, which means that we're now going to send bad blood over to the good side, right? So if we have RDS, it can actually cause that PDA to actually pop open and develop that right to left shunt in this situation. In this situation, I'll repeat that again. In this situation, that PDA, when it pops open, could be a right to left shunt. Isn't that crazy? Which would just add on to the terribleness of RDS, because you have poor compliance, high resistance, you're not cycling a lot of blood through your lungs because of the pulmonary hypertension. So that's why in some of these kids, the more term a kid is, the more likely they'll respond to things like nitric oxide. So then we can give them things like nitric oxide or Viagra, right, sildenafil. So we can give them those things to help dilate that pulmonary capillary and help with that perfusion. All right, so one of the most commonly seen cardiac defects in the NICU. So this is something that you'll be very familiar with. That's why I spend so long talking with it to you guys. Thank me later. So that way you'll be well prepared for understanding the physiology that's going on here. So understand an RDS can actually cause that PDA to pop open and increase the shunting that's already going on with that condition. Isn't that crazy? Delayed closure is inversely related to gestational age. I love that term, which is just a fancy way of saying the more preterm a kid is, the more likely they'll have a delayed closure of the arteriosus. So if you got a kid that's 24 weeks, it's going to take them a lot longer to have that thing close up than a kid that's 34 weeks. Big difference, right? Big difference. That's all that statement is saying there. The younger they are, the longer it's going to be before that closes up. Even if we're using things like indomethacin and ibuprofen for those kids to help close that up. 20% of infants more than 32 weeks of gestation have it, to 60% in infants less than 28 weeks. So take a wild guess. If you have a kid that's less than 28 weeks, there's a good probability, right, a 60% chance, that's according to whenever this was published, that kid has a PDA going on. So watch out for their lung compliance, watch out for pulmonary edema, watch out for low surfactant, and that's why they may just go ahead and resurf, diuretics, things like that. And they'll use a little bit of diuretics in the NICU. They usually use a diuretic called aldactazide, which is a potassium-sparing diuretic, so that way it doesn't really mess up their electrolytes, and it doesn't pull off fluid as aggressively, so it doesn't affect their blood pressures significantly, which is great. All right, so what's the pathophysiology? I love this. I pulled these pictures directly from your book, so hopefully you're following along there. Much better pictures than what I can draw. As pulmonary vascular resistance decreases, the aortic pressure, right? So this is, hey, a kid is born and they take their first breath. What happens to pulmonary vascular resistance? Well, pulmonary vascular resistance, when you take a breath, when you expand your lung tissue, what happens to those capillaries, right? Those capillaries all expand in your lungs, right? As you take a really deep breath, right, all those capillaries expand because you have such negative thoracic pressure. So that will then decrease pulmonary vascular resistance because the capillaries are now dilated. So aortic pressures then will be higher than pulmonary artery pressures. This is perfect. This is exactly what we want to happen. So the blood pressure, once you're born, changes from being higher on your right side to now changes to hopefully the rest of your life where it's higher on the left side, okay? So the aortic pressures will be higher than the pulmonary pressures, and this will result in a left to right shunt. So as long as there's higher pressure in the left side of the blood flow, it is a left to right shunt, or an acyanotic shunt, right? Or I should say correct, right? That's what we're looking at here. So it's going to be an acyanotic shunt. So as long as that pressure is higher on the left side, you're good to go. If something happens like pulmonary hypertension, then you're going to have an issue where this could switch and go to a right to left shunt. Isn't that exciting? All right, signs and symptoms of a PDA. It depends on the degree of the shunting, right? How significant it is. So if it's significant enough, it can cause just basic tachypnea, right? The kid's breathing fast. You'll hear this continuous murmur. You won't hear those staccato lub-dub. It won't be that closure sound. You'll hear more of a whooshing, whoosh, 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 that continuous. Very similar to what you hear on an ultrasound. If you ever listen to a heartbeat on an ultrasound, a pregnant mom ultrasound, sounds almost identical there. The difference in oxygenation can be there if it's significant enough, your pre and post ductal blood. So there's two ways to look at this, and I think I have a resource in the resources tab that talks about pre and post ductal. You can do it two ways. You can either draw a blood gas and look at the PaO2 and see the difference. So you can draw a pre-ductal on the right upper extremity and then a post-ductal on any of the other extremities, and look for 15 millimeter mercury difference in the PaO2. That is one way of doing that, and that says that there is what we consider significant shunting. So let's say there's only a difference of 5 millimeters of mercury. That's not considered significant for the shunting. In other words, it's there, it's just very minimal. So when we're looking at that, that might be a more direct method to do it. However, in my career, we never did it that way, but that's just my mileage. Your mileage may vary. But what we traditionally do is we use the pulse ox. So we can use an ABG, or we can use pulse ox. So pulse ox, if we do a preductal, which is in the right upper extremity, and there's a 5%, more than a 5% then difference between the preductal and postductal, then that would be significant for a PDA being open. In other words, we see that it's open. So if you put a pulse ox on their right hand and a pulse ox on their right foot, the right hand, remember, is going to be preductal. So if you see that the pulse ox on the right hand is 95% and you see the pulse ox on the right foot is 88%, well, that's more than 5%, and that would be significant for a PDA being open. So that's one of the things, and they do this for most newborns now, is they do a pre and post ductal. This is something that they actually do for most newborns now, just to verify that they don't have like a PDA that's going on, or it screens for heart defects is what they call it, but that's something that they'll do now. So that's the one I traditionally do. My recommendation to you is, if we're doing this and you're using it to titrate FiO2s, mark which pulse ox is preductal. Right, so if you go and get a separate pulse ox, then just get some tape and mark it as preductal or something like that. Make sure people know which pulse ox is preductal in the NICU and which one is not. All right, so if the one on the monitor is postductal, that's fine. Just understand that we're titrating FiO2s and everything based upon the preductal usually. Chest x-rays on these babies are usually normal. However, if they have pulmonary edema with it, that's where you'll see pulmonary vascular markings, right? The key thing there is looking at their hilar area on their x-ray, and you'll see the hilar infiltration that can go on there. So how do you diagnose a PDA? Well, it's pretty straightforward. If you have an echo, and people that do the echo, you can actually see it directly move. You can see the blood flow moving through there. It's kind of cool. So pre and post ductal studies is another way to do this. So you can do it with the ABG, where we have to have a difference of 15 millimeters mercury, or pulse ox, which would be a difference of 5% on the pulse ox. And also they can also see if they hear that murmur, that continuous murmur. That's another way they could diagnose it as well. So there's 3 ways. Which way is definitive? You're going to tell me it is echo. And of course, for all these congenital heart defects, take a wild guess which one is going to be the most definitive way to diagnose it. Yes, it's the echo. Those echo people will be your best friends. Okay, prognosis. Over time, you're going to have that increase of blood flow if it's a left to right shunt, right? And it can cause what's called atrial dilation and left ventricular volume overload. In other words, they can develop a baby version of congestive heart failure, CHF. So it's a baby version of CHF if it's prolonged, if it's significant enough. You might also lead to pulmonary hypertension, which is what we just talked about a little while ago, where we have that backup of blood flow into the pulmonary artery, into the pulmonary vascular system, which could then cause that backup and ultimately pulmonary hypertension. It might make it harder to wean these patients because they might develop pulmonary edema, just like we talked about. Pulmonary edema does what to your lung compliance? Well, it stiffens up lung compliance because now you have things that are diluting the effect of surfactant. Remember, surfactant decreases Laplace's law, and Laplace's law says that water molecules want to stick together. Right? That's surface tension. Water molecules want to stick together. And if we put a bunch of fluid, which contains water, into their alveoli, we're going to increase surface tension and therefore dilute the effect of surfactant and therefore decrease their lung compliance. They'll have more atelectasis, they'll have stiffer lungs, they'll have a lot less surface area to exchange gas, so that both their oxygen and ventilation will be affected if it's severe enough. So what would the lung compliance be at this stage? What would happen? Well, if they're in pressure control ventilation, what would happen to their minute ventilation? If a baby's in pressure control, what would happen to their minute ventilation with poor lung compliance? Well, it'd go down, right? Because their tidal volume would decrease and so on. What would happen if their pulmonary edema got better? We give the kid diuretics, or if they were able to take it, things like that. Well, the lung compliance would improve. We'd see higher minute ventilation if they're on pressure control. All right, so how do we treat this? So if you have a PDA and it's significant enough to start treating, just make sure they're euvolemic. So we're not overloading, we're not pulling too much pressure off the kid. Remember, you pull too much fluid off the kid, not only can you mess up their electrolytes, but you can also mess up their blood pressure, you can mess up a lot of things. So try to keep them even, just like your ARDS patients. We don't give them too much volume, you don't want to let them be dry either, both of them are bad. Same thing here. Adequate oxygen delivery. So usually we're going to titrate that due to preductal. Preductal tells us how much oxygen is going to their head, to the brain, right? That's the big thing there. Obviously we don't postductal, it'll be like 60%, but usually it's only a difference of like 5 to 7% traditionally for a lot of shunts, but make sure there's just adequate delivery. They can do things like increase the PEEP on the ventilator. So why would that help? Well, this will decrease the pulmonary blood flow by increasing PVR. We're back pressuring it, so we don't have as much pulmonary edema. So remember a CHF, and one of the classic treatments for someone that's working hard with the CHF exacerbation is putting them on positive pressure like CPAP, right? A CPAP of at least 10 or more for an adult. The reason there is you're going to expand the alveoli significantly, and you're going to sort of make the blood vessel smaller, so there's less blood. Even though there's a huge amount of volume of blood, there's less blood that has the opportunity to seep a lot of fluid into the alveoli. So there's less seeping into the alveoli. So it should help stop or reduce the amount of edema that's currently going on. So increasing their CPAP level or increasing their PEEP that might actually help on these babies. Just understand if it's too much, if you do that too much, then you can cause a right to left. But that's all, neither here nor there. Other treatments, so increasing PEEP, keeping them euvolemic, make sure their oxygen delivery is adequate. NSAIDs, and that's where we talk about indomethacin and ibuprofen. Indomethacin is traditionally used first, and then down the road, if it's still open, then they'll usually use ibuprofen. Indomethacin can be used prophylactically. In other words, they might just give it just in general to help close it off. Side effects, very uncommon with this. Ibuprofen can also be used. It's usually subsequent. Most of the time, ibuprofen's more associated with chronic lung disease when compared to indomethacin. That's why they try to use indomethacin first. The other thing that they can do, and they don't do it as much anymore, is do what's called a PDA ligation. And this is something that's sort of out of style nowadays. Your book still talks about that, where they go in and they literally ligate the ductus arteriosus. But if the kid is big enough and they're experiencing too many episodes of RDS, or too many episodes of pulmonary edema is what I should say, then they might go ahead and do the plug procedure. And this is where they go in and they float a plug in between the pulmonary in the ductus arteriosus. They plug it off, and so therefore everything shrivels and it closes off altogether. So this is only done if the benefits outweigh the risks ultimately. In other words, the kid has too many effects from the pulmonary edema or too many effects from the PDA being open, then they'll go ahead and do that procedure. But traditionally they don't see a ton of issues. I mean, it does create complications if the PDA is open, of course, that's what we've been talking about, but traditionally your benefits have to be there if they're going to do one of these. It used to be they would do ligations left and right, but there's a study that of course showed that there wasn't a great deal of difference in the long-term outcome, the days in the NICU, so on and so forth, of kids that have ligations compared to those that didn't. And that's why a lot of the PDA fixes, other than just giving them the indomethacin or ibuprofen, that's why a lot of those went out of favor, right? Both of those are sort of a bedside procedure. All right, let's talk about atrial septal defects. So this is just the opening in between the left and the right atria. So this isn't the foramen ovale. This is just a hole is there in between the left and right atria. So that's it. There's just a hole that's there. Only about 8% of children with ASDs develop symptoms before they're 2 years old. Only 8%. So less than 10% of kids develop symptoms before they're 2 years old. So how significant or how critical, how crucial is an ASD, do you think? Well, it's not very critical. It's not very crucial there, obviously. If it takes till they're 2 before they actually have any symptoms going on here. And I have adults that would come into our PFT lab that were diagnosed with asthma, and then when it comes down to it, they had a PFO or an ASD that was just undiagnosed. Thanks, Bubble Study on Echo. That's how you would find that out. But they would wheeze because they had pulmonary hypertension and increased PVR. As they would exercise, what happens to your blood pressure? Well, your blood pressure goes up, especially in your left side of your heart, and so then they would have this backup of blood going into the right side, which then go to the pulmonary artery. Oh, sorry, pulmonary artery. That was the vena cava. Pulmonary artery, and then cause pulmonary edema, which is when they would wheeze, right? And then, hey, I have shortness of breath and I wheeze whenever I exercise. What's the doctor going to say? It's most likely exercise-induced asthma, of course. And so they're going to come in for a PFT, and I'm going to be like, your lung function is normal. And then they go for the bubble study echo, and they're going to be like, yeah, there's bubbles crossing over. There you go. All right, so not very significant is my whole thing. I need to shorten up my phrasing here. This is considered a left to right shunt. So is this cyanotic or acyanotic? I know I'm sort of jumping here, but I just want you thinking about that, right? So would it produce cyanosis if we have good blood mixing with bad? No. So this would be considered acyanotic. All right. This can lead to right atrial enlargement. Of course, we're adding extra blood volume to the right atria here. It can overload the right ventricle, of course, and increase pulmonary blood flow, of course. That's what I just talked to you about, those people that were misdiagnosed with asthma there when they actually had a hole in between their atria. Over time, you can have right ventricular hypertrophy. It says congestive heart failure, but really, and the book says that it's congestive heart failure, but really this would be cor pulmonale, right? That's what you're looking at here, is cor pulmonale. And pulmonary vascular disease, which would be like pulmonary hypertension, things like that. Infants with ASDs are rarely symptomatic, and they may have these well into adulthood, and this is where I would see this in our PFT lab here and there, right? So ASDs, is it crucial that you catch this? Will you be able to catch this? Will you see symptoms and everything where you can catch this right away? Absolutely not. It's not one of those life-threatening situations traditionally. So understand it's very minute, and in fact, over time, as these kids grow and develop, usually they'll close spontaneously. They won't need an intervention if they do know about it. So signs and symptoms, like I said, it's very rarely symptomatic, especially if people can go into adulthood. The most common symptoms include dyspnea. They fatigue pretty easily. They might feel palpitations. This is why we see this every once in a while, where they'd come in for a PFT and an echocardiogram. They might have an atrial arrhythmia, like this would most likely be an AFib or aflutter here. A syncope, they might have fainting spells here and there. Stroke or heart failure is possible. And we talked about that. That would be more of an extreme case here. And most common symptom developed in adults is usually that palpitations, right? And that's because of the atrial arrhythmia part of it. And that's why they really notice it. They come in with chest pain, or they have something like that that feels funny, and they're getting it checked out, and you're doing an EKG, and they have an atrial situation going on, and then they'll do an exercise test or a echo and a PFT. All right, so guess what the best way to diagnose this is? Yeah, the good old echocardiogram. Chest x-rays usually are normal unless there's a CHF change that goes on with it, so that's what would be a late stage catch. If you catch it on an x-ray, it's a late catch. A cardiomegaly obviously can be there. Pulmonary vascular markings, if you look for hilar infiltrates, can be there. EKG. Normal sinus rhythm, you might see more right axis deviation. So hopefully you remember right axis deviation usually means pulmonary issue. Left axis deviation usually means cardiac issue. So when you're looking at a right axis deviation, it means there's a lot of stress on the right side of the heart, or pulmonary hypertension type situation is going on. So remember, most every pulmonary disease causes pulmonary hypertension, right? Causes pulmonary vasoconstriction, which is pulmonary hypertension. Right, so that's why you'll see right axis deviation a lot on pulmonary patients. Well, you can also see it on cardiac patients here if they have that cor pulmonale, right? More stress on the right side of the heart, therefore it's a right axis deviation. All right, ventricular conduction could also be there and show up as a bundle branch block. Remember the bundle branch blocks? They look like wide QRSs. I do a bad job at drawing EKG. I'm glad I don't have to draw EKGs all day. You guys can look up a bundle branch block image pretty quickly. You'll see that I did the best I could. At least give me props for that. Prognosis, only 8% of children develop symptoms before they're 2. So obviously it's a very good prognosis. Even if they don't catch it, a lot of times they'll close spontaneously. And then it can last into adulthood as long as people are good about getting themselves checked out or getting physicals, a yearly physical, thing like that, like can really save them from heartache in the long run. You see what I did there? I should not make jokes during this. All right, treatment, spontaneous closure. That's what I was talking about before. Spontaneous closure usually occurs pretty young kids. It might wait till they're like 5 years old. If we do surgery, usually you wait till a kid is at least 2 years old or older, and that's more of just an anesthesia risk than anything on a lot of our kids. So they'll typically delay this too in case there is a spontaneous closure. They just do an echo, look at it, and see if it's spontaneously closed. If not, then they might go in and just do a small surgical repair. Usually they can go through the sternum, which is that a very popular one? Not that I'm aware of. A lot of them will just do this option, which is go into the cath lab, and they use a catheter to close it. Seems a lot better. This avoids a sternotomy, which those do not look very gentle at all, and bypass. So we can avoid both of these if we can. If it was your kid, would you want to avoid a sternotomy and bypass? Yeah, I would think so, but moving on. All right, so we covered an atrial septal defect. Now we'll cover a VSD, a ventricle septal defect. So there's a hole in the ventricle. So if you're looking at the picture over here, right, between the right and the left ventricle, there's a hole. So take a wild guess. If the pressure is greater on the left side of the heart than the right side of the heart, would this be cyanotic or acyanotic? Well, if we have higher pressure on the left side of the heart, we'd have mostly good blood mixing with the bad side over here. So this would be considered acyanotic. So these happen as well. These are the most common congenital heart defect, and a lot of times some of these things will happen with other conditions like tetralogy of Fallot, and we'll talk about that one in the next presentation, but it'll happen with other conditions as well. So 2 to 7% of live births, so that's a number, right? So you may see it depending on how busy the NICU is that you work with, things like that. Communication between the right and left ventricles may occur in a single component or other anomaly, like we see with a tetralogy of Fallot. And tetralogy of Fallot, take a wild guess how many different things are going in there. Tetralogy, 4, right? There's 4 different things. So that VST is actually going to be an important part of that, because what happens in tetralogy of Fallot as well, and I'll preview it here, is the pulmonary trunk is narrowed. So your ability to send blood through the pulmonary artery is severely impaired. This is a big issue. And actually one of the big treatments for tetralogy of Fallot would be to open this first, right? To get this fixed first. So that way you're not shunting sorry, where's my purple? There it is. Shunting bad blood over here. Because what happens if the pulmonary artery is narrow? Well, you're going to increase right atrial, right ventricle pressure. and then now you're going to have a right to left shunt. So it's going to not be acyanotic anymore, and then you're going to have a lot of issues. So that's one of the biggest treatments right away, is to get that pulmonary artery opened as much as we can. So it can happen by itself where you have a VSD, or it happens with other conditions. Isn't that amazing? All right. So transposition of the great vessels or great arteries, TGA. That's one of the things it's called, or TGV. Same thing. It can happen in that condition as well. All right, so what's going on here? Well, this is a left to right shunt. So which one of these is it? If it's a left to right shunt, it is acyanotic. Left ventricular volume overload can easily happen on this because you might have that back pressure just filling up in there. A left atrial enlargement, increased pulmonary blood flow, because now it's a left to right shunt, just like your PDA. It can increase the pulmonary blood flow. The size of the defect will ultimately determine how severe each individual case is. So you might have a kid that has a VSD and there's no symptoms. They can see it on an echo, but really there's nothing significant about it. It's not causing pulmonary edema or atrial enlargement or anything like that. Other kids, it could be just ginormous and causing a lot of issues. So it just depends how open that VSD is. So the size is going to be hard. Usually occurs during systole is when we're going to see it. So a large shunt, a large VSD will cause CHF and pulmonary hypertension symptoms that we'll start to see in there. So acyanotic, so this kid could be a good candidate for things like nitric, things like that. So smaller defects, if they're smaller defects, like I said, they may not even have any significant symptoms from it. So smaller defects with greater left ventricular pressures than right ventricular pressures are known as restrictive VSDs. So if you're at like a children's hospital of some sort and they say it's a restrictive VSD, that's what it's saying, that the left pressure is greater than the right ventricular pressure. So it's a left to right shunt. Children with restrictive VSDs are usually asymptomatic. That's what I was saying earlier. They may not even know they have it unless they're looking at an echo, right? If the pulmonary vascular resistance is very high, like a kid is hypoxic or acidotic, right? Hypoxia and acidosis are big factors in causing pulmonary hypertension, okay? So if that's there, then this can switch from a left to right shunt to a right to left. So it can switch from being acyanotic to becoming subsequently cyanotic. In that condition, it's called Eisenmanger's syndrome, right? I say that really fast because I don't know the right way to pronounce it. So brutal honesty, but hopefully you appreciate that. Give me character points, please. All right, the occurrence of cyanosis after infancy usually suggests that this is exactly what's happened. We have greater right pressures than left pressures, and now it's causing a right to left shunt. So that's the Eisenmanger's syndrome. So you'll see this on a cardiac worksheet. So that's something that I might ask you about, obviously, in the near future. How do we diagnose a VSD? Well, hey, the most accurate way, echocardiogram. And remember, RTs can actually run echoes. They can go through extra training and become sonographers and things like that. MRI, they can see it on cardiac MRI. Remember, cardiac MRI is a lot more valuable than pulmonary MRI. So cardiac MRI can work as well in this case. Chest X-ray, usually normal unless they have pulmonary hypertension with it. That's where you would see it there, or if they have vascular markings from that pulmonary edema component to it. But remember, there's a lot of different things that can cause pulmonary edema. So is it specific to a VSD if you see pulmonary edema? No. Right? So that's why an echo would be probably the most accurate, and then an MRI as well. EKG, if you did a 12 lead on these little guys, maybe lower voltage and some cardiomegaly on it, so that would be something you could see there, but not something significant. So here you see the right ventricle and left ventricle on the echo, and you can see the opening in between there. All right, and here's the left atria down here at left ventricle, and you can see that opening in between the two, and so that's where you see that on an echocardiogram. So what's the prognosis here? Children with small VSDs are usually asymptomatic. Good long-term prognosis, in other words, not much to worry about long-term. Heart failure, if they make it out of infancy and they don't really have a lot of symptoms, pretty rare to happen. Could happen, but very rarely. Some types usually close spontaneously. Hey, kids. Man, kids can do a lot of cool things spontaneously there. Sometimes not so cool. That's a parent joke. All right, VSDs are the most common lesions in a lot of chromosome issues. So trisomy 13, trisomy 18, which is Edwards syndrome, and even trisomy 21. Those babies that have those chromosomal disorders might also have a VSD that goes along with, or it's more likely that they're associated. It's not necessarily causation, it's more correlation, I guess. It would be a better way to look at it. 95% of patients with VSTs are not associated with the chromosomal. So even if they do have a trisomy, it doesn't mean that they will have it. And if they have it, it doesn't mean they have a trisomy. That's why I say it's more correlational data than causation data. So a kid could have a VSD and not have a chromosomal defect. Hopefully that makes sense. More common in female patients than in male patients, barely, but it's there. It's a more than 3% difference, so guess what? It's technically statistically significant. Boo. All right, treatment. VSDs, how do they treat it? Well, if they have signs of heart failure, then they're going to manage it with diuretics and digoxin, just like you would manage regular heart failure. Well, go figure. Hey. This is where your advanced pharmacology class comes into play. Huzzah! Medical therapy usually is what they're going to start with. If that doesn't work, then that's when they can go into surgical closure. Right? They can either go and bypass and close it with a patch when they're looking at it, so they can work on that. If it's severe enough, they can do a pulmonary artery banding. And repair the defect. It's pretty crazy. Or they can do a transcatheter closure. Take a wild guess which one's more popular out there as of when this book was written. In the cardiac cath lab. So cath lab once again saves the day. The device is usually reserved for older children, right, with muscular VSDs, more of that muscular VSD issue going on. So there's a couple different options for you. All right, coarctation of the aorta. We're making it there, right? I've only did a couple things here. That's why I split this presentation up. Coarctation of the aorta is going to be a big one to look at. There are athletes that are out there, and this is one of the reasons why athletes get physicals out there. This is something that may go undetected depending on how severe or significant it is. And I already previewed coarctation as one of those. If it's a severe enough coarctation, it could be a shunt-dependent thing. A lot of people out there that have a coarctation may not know they have it as well. So coarctation of the aorta is relatively common. 5 to 8% of all congenital heart defects, not of all births, not of all humans, but of all congenital heart defects. So there is a possibility you could see this out there. There's a narrowing of the thoracic aorta. All right, and the proximity of the ductus arteriosus. So in the general area of the ductus arteriosus. Now, it can be post-ductus arteriosus. It can be pre-ductus arteriosus. In the example that I drew earlier when I was talking about shunt dependence, ones where it could help, that was obviously where it was pre-ductal. And we were able to bypass it with the ductus arteriosus to get good perfusion. So it can vary. It can be right there. It can be previous, proximal. It can be distal to the ductus arteriosus. It just varies. So it may be the sort. This is exactly what I was just saying. There you go. May be present in the neonatal period or later in infancy or childhood. They may not know that they have it until later on. There are athletes that collapse and they just develop so much high pressure from their coarctation that it's one of those things that could cause, besides second impact syndrome on your collision sports. I call them collision. There's contact sports and then there's collision sports. But in a collision sport, and that includes cheerleading, by the way. All right, I'm just saying, those collision sports, that it can easily cause a backup of pressure. That the second impact syndrome and coarctation of the aorta are some of the bigger things to be worried about with a lot of student athletes out there. A lot of that stress they're putting on their heart and on the coarctation can cause severe cardiac stress and cause them to go into heart failure and significant situations there. So that's why it's important. One of the reasons why it's important to get those pre-athletic physicals for those kids. Pathophysiology here, you're going to have an increase in afterload to the left ventricle. So there's a lot of back pressure of the aorta. So here we have, let's do this. Here we have the aorta. And so there's a coarctation right here. Do you guys see my fancy coarctation? All right, give me props for trying. So what happens here, there's the coarctation. What's going to happen behind it? Like what happens when there's an accident on the highway? All the traffic behind it backs up, right? And it's going to cause a lot of back pressure. Well, eventually that's going to increase the afterload, or how much stays in the left ventricle, because only so much can pump against that resistance for the aorta, right? Going through that aortic semilunar valve. So that's going to back up a lot of pressure in that left ventricle, which then increases the workload of the left ventricle. So left ventricular stroke work index. Whew. Do you remember that from our disease class? Left ventricular stroke work index was one of the things that we talked about there, and that's what you'll see here, is that will increase that left ventricular stroke work index. So it makes the heart work harder, makes the heart consume more oxygen, so your VO2 actually increases. So you have an increase in cardiac oxygen consumption. So this kid might have a higher metabolic need for oxygen as well. So it's severe enough, it might cause myocardial ischemia because their VO2 is increased, right? And as a result here, all this extra pressure in the left ventricle, then we'll have extra left pressure in the left atria, which will then back up blood flow into the pulmonary veins, which then backs up into the lungs and causes pulmonary edema, right? Do you sort of see this whole backflow symptoms going back to the lungs causing that pulmonary edema? That's pretty crazy stuff. Now this one also can cause congestive heart failure. That's what we're seeing here. So systemic blood flow in a severe case, so this is a severe case that I'm telling you about here, is ductal dependent. So systemic blood flow here is ductal dependent. In other words, if we have a PDA, and let's say the pulmonary artery is here, and it goes to the aorta, distal to where the coarctation is, then we can still get blood from the pulmonary artery to that circulation. Even though it's mixed blood now, we can still get some perfusion to the rest of the organs. So if it's a severe enough coarctation, they will be ductal dependent, right? That's what it's saying there. They will be ductal dependent if it's severe enough. Traditionally, is this cyanotic or acyanotic? Well, this would be acyanotic, right? Something we already talked about. Signs and symptoms usually may be present with systemic hypoperfusion. In other words, low pulse pressure, low blood pressure, right? Caused by the closure of the ductus arteriosus. So let's say you're at a delivery, all right? Let me give you a scenario. Mentally put yourself in your Pima scrubs and Pima stethoscope, right? Have fun, right? Mentally put yourself in a clinical scenario of some sort, and you're in the hospital, and a kid suddenly has low blood pressure after you're giving them oxygen at delivery. Okay, so kids starting to develop low blood pressure, you start to feel their pulse. You don't feel a good strong pulse in their lower extremities. They start to turn pale. And this has been a couple of hours since birth. Their blood pressure is low. They start to turn pale. They have a systolic murmur, right? So this is something where you may actually have to go switch to room air and use more hypoxic gas therapy, try to get that pulmonary artery, patent ductus arteriosus, back open again, right? So this is something where you need to treat this kid as a ductal dependent kid and turn it to room air and run well, I'll talk about the 40 and 40 technique here in a second, and you probably have already seen it in your book, but the 40 and 40 is going to be your technique if it is severe. In other words, you don't feel good strong pressures. Well, how would I know? What's one of my bedside techniques that I can know? Well, you have upper extremity hypertension, and the only clue is the underlying lesion. But if they have upper extremity hypertension and lower extremity hypoperfusion, what would be the strength of the pulse in their leg compared to the pulse in their right arm? The strength of the pulse in their right arm would be strong. You would have like you would have a bounding pulse. Now, if you're feeling on their leg, it's going to be a very low pulse. It's going to be a very thready pulse if you feel one at all. So if you see that gradient or you palpate that gradient, that could be a sign of a coarctation. So if you're asking me, how would I know, Derek, at the bedside that this could be a coarctation, then that would be it. That would be checking the pulse on their right upper extremity and the pulse on their right leg or their left leg, right? The femoral pulse, right? Try to see if you feel the gradient difference. If you feel a stronger pulse in their upper extremity and a weak, almost non-existent pulse in their lower extremity, that could be a sign of a severe coarctation. That would be, hey, treat this kid like a shunt-dependent kid. So hopefully I just helped you there a little bit. All right, diagnosing it includes blood pressure discrepancies. Hey, this is sort of like what I said, only I'm not using a blood pressure cuff because sometimes you don't have it with you. So reduced or absent lower extremity pulses on palpation. That's exactly what I just said previously. Chest x-ray, that's going to take some time before you see it there, but if it's severe enough, you're going to see cardiomegaly and pulmonary congestion. But cardiomegaly and pulmonary congestion, those go along with a lot of different things, so it's not specific to this. So older children, and this is if it's less severe, right? Older children usually will have some cardiomegaly, some rib notching, things like that could show up on their x-rays. The best way to diagnose this, one of these two, echocardiogram or a cardiac MRI. All right, so how do we treat it? Well, it depends how severe it is. If it is severe enough, right, where we're treating this kid as shunt dependent, so it's severe enough, we can give them prostaglandin E1. What does that do? Does it keep it open or close it? Well, E1 restores the patency of the arteriosus. So E1 maintains patency, so we give it to reopen up or keep that patent. All right, it's the albuterol of the blood vessels. Dilate that vessel. Dilate it. It may also have a significant ventricular dysfunction, right? Like a heart failure, acidosis. They might need to be on positive inotropes to help their blood pressure. Remember, their perfusion to their lower extremities very poor. So they might have to be on inotropes, diurese them, or even obviously ventilatory support, of course, if it's severe enough. Surgery is not delayed. In other words, this is something that's more risk to delaying the surgery than benefit, or more benefits than risks. So we need to go ahead and go do that. So if it's less severe, obviously in older infants and children's, infant and kids, they might be more elective. They're just going to watch it, right? Follow up with the cardiologist here and there. Common approaches to fixing it. So you can do an end-to-end anastomosis, so they can actually cut out the stenotic area, or the coarced area, I should say, or that narrowed area. They can do a patch that enlarges the area. They can do a subclavian patch, right, which actually uses a flap from the subclavian artery, which is pretty crazy. They can do an extended resection, or the most commonly procedure in the little guys, the neonates, is the resection with the end-to-end anastomosis. So they're going to cut out the coarced area and sew the two ends together. Obviously this one, not as big, you don't have to go through the sternum. It's usually a left thoracoscopy or